or moving towards addressing health inequities as it relates to accessing health information and promoting disease prevention and health promotion. And then I'm going to wrap up the discussion with just some key things to keep in mind that we want to be mindful of to ensure that if your work either sits within the digital health space or is informed by digital health, or on the other side, your work informs digital health. When working with communities of color and marginalized and minoritized groups, that there's some key things to keep in mind to ensure that we're not exacerbating the current health inequities, health disparities, as well as digital health inequities. So with that said, I'm going to go ahead and move right along. So my work started initially, or what informed my work, one of the examples is more recent when I was in my graduate program at Howard University. And at the time, I was really interested in exploring the relationship as it relates to patient-provider communication between Black men and their providers around prostate cancer. And so this image that you see here is represents a lot of my passion as it relates to all of my work. I cannot engage in any research without being connected to it passionately or personally, as well as professionally. My passion is rooted in community. My passion is rooted in the Black community, a marginalized, minoritized community, and family. And so who you see here with a little hat on and glasses is my father in the top left-hand corner right here, and then my grandfather. And some of you all might recognize this blue ribbon to be a symbol of prostate cancer. And so during that time, I understood that patient-provider communication could play a key role in helping Black men and their providers determine the best prevention as well as treatment decision options when either trying to prevent prostate cancer and or treat it. And so both of my grandfather and father were diagnosed and survived prostate cancer, but they were diagnosed with prostate cancer. And so they really informed a lot of that work and during my doctoral degree, and then also the various relationships and engagement that I had with the community around patient-provider communication in the Black community. I was really, really engaged and interested. And so I continued on, completed my degree, and finished with that focus on patient-provider communication as it relates to Black men. But I recognized as I transitioned on to my postdoc at NIH and the National Cancer Institute that health information, health decisions, prevention, promotion, and disease management did not only happen within the clinical setting. And so I wanted to further explore how other factors played a role. And there were some things that were highlighted. They weren't key findings in my dissertation, but there were brief mentions in some of the data about how internet played a role in information sources and channels for the Black men, and that collaborated with me on my dissertation. And so I started thinking during my postdoctoral training, I was thinking, we know that on average, Americans only go to their doctor's office visits about maybe 4 times a year. So outside of those doctor's office visits, there are so many other things that are occurring, right? There are things that are occurring at the individual level. We all know about our attitudes and beliefs and skills and behaviors as it relates to certain health issues, health behaviors and outcomes. There are things that are happening in the interpersonal relationship outside of the clinical setting as it relates to friends and family that are influencing our health decisions. There are community level things that are influencing either in a positive and or negative way, societal level policies, right? And so I started to say, okay, well, technology is moving at a really rapid pace within the clinical setting and outside of the clinical setting. And we have this thing still present to this day known as the digital divide. And many marginalized communities fall within this digital divide, unfortunately, due to these various levels, especially at the societal level, policies, and various social determinants of health that are playing a role in that. And so I said, I want to just start an initial exploration of how technology in the clinical setting, as well as technology in the non-clinical setting, might inform digital health design. So that brought me to my first paper in this digital health space during my postdoc, titled Implications of Social Media Use on Health Information Technology Engagement using the National Cancer Institute's Health Information National Trend Survey cycle at that time. And so we learned in that study that when looking at clinical health information technology activities and looking at non-clinical health information social media activities, that they have a close relationship. So individuals who look for health information on social media are likely to communicate with their doctors using email, likely to share health information via the internet with their healthcare providers. And so we said, wow, that's important, right? Because that's helping to inform, like, well, if community members are doing this in the non-clinical space, that's giving us some insight to what they might do in the clinical space when it comes to like patient portals, telehealth, electronic health record access, and so forth. Well, in that analysis, we also saw that there were some racial ethnic differences. One in particular, we found that non-Hispanic Black individuals were less likely to report actively using social media to share health-related information in comparison to other racial ethnic groups. So although in general, when we think about general information for social media use, Black adults are likely to engage, but when it comes to health information, it varied specifically for social media. Now, some of you might be thinking, well, why should we care about social media use as it relates to health information? Well, we know as time has gone on, social media does influence health behaviors, health attitudes, as well as what individuals choose to believe and not believe, right? Which is why we're in this landscape and environment of misinformation and disinformation. So it was important to be able to see how social media use might play a role in clinical settings. And those were some of the non-clinical variables that were available at the time in the Health Information National Trend Survey. So when I saw that, I started to realize that this story around digital health, this space around digital health, presents opportunities to contribute to addressing health disparities, but also recognizing that in the same space that it can create opportunities, if not approached carefully, if certain things are not taken into consideration continuously throughout the cycle when developing these platforms, when promoting these platforms, when assessing these platforms, it can actually exacerbate these issues. So as a result, I said, I want to further explore all the things as it relates to digital health when it comes to marginalized minoritized communities. And before I get into what I mean by all the things, and give you an example of one of the things within all of the things, I want to just, for the context of this presentation, lay out the definition of digital health. Because sometimes when people hear the term digital health, even those within the academic and research space, there are different ideas of what it means. So digital health is the definition is the use of information technologies to prevent, manage conditions and illnesses. And it can be for various reasons. It can be within the outside of the clinical setting, for example, like using health apps, like your Calm meditation apps, like your food tracker, diet apps, and so forth, right? But it can also be things like wearables, like an Oura ring that's monitoring your sleep patterns, that is monitoring your steps, your physical activity. It could be your Fitbit or smart health watch and so forth, or Apple Watch. But it could also be within the clinical setting, right? EHR systems that healthcare providers are utilizing to be able to access individual patients' information, but also share information between provider systems, depending on their interoperability. And then also within the clinical setting and outside of the clinical setting, there are patient portals, which I'm sure many of us have probably engaged in or considered engaging in or have been offered the opportunity, where a patient can view and see their health records. They can also, the reason why it can be connected to non-clinical spaces, because they can connect, some of these patient portals can allow patients to connect data from their smartphones, right, to their clinical setting. And then, of course, which became extremely popular during COVID-19 telehealth. And we saw an extreme spike in telehealth during COVID-19 because we were in isolation and needed to have this safe distance, but still needed to receive care either for physical and mental health and wellness. So that is digital health for those that maybe needed a more specific definition and examples. And I also want to remind individuals that digital health also includes looking for health information using search engines like Google, also looking for health information on social media, whether it is through social media platforms where we're just lurkers or seekers of information, or when we are actually sharing health information and we are content creators or generators of that information. So those are examples of digital health. And so within the context of digital health, unfortunately, we still see a lot of inequities that persist and exist. Now, before I talk about those inequities, because that is the way that I am framing my talk this afternoon, I do want to acknowledge that we have seen a lot of progress. We are moving along as it relates to digital health equity, right? We have seen in studies and national reports and in smaller studies that marginalized communities of color are wanting to engage in the use of digital health to manage their health conditions and prevent health conditions. But we do want to recognize that there is still a digital divide that is occurring in just general that does make it, that still has not allowed us to close the digital health equity gap, because the general digital gap still remains. So let's talk about some of the reasons for our digital health inequities. Well, for the first one is that there is limited access as it relates to broadband and 5G. So some of us might be wondering, well, I mean, I thought that we had been moving things along, right? Because there are different initiatives to create affordability access programs. But there are, although we are seeing some adjustments as it relates to cost in some spaces, or in some regions of the country, there's still areas in the country that do not have broadband access, do not have 5G access for individuals to be able to utilize through either their smartphones and or their laptops and or desktops. We also see economic inequities. Oh, and before I move on to the economic inequities, I also want to note that within that broadband and 5G access, there's what we are, what is known as digital redlining. So digital redlining is when individuals who are in charge of those infrastructures for creating spaces to allow for various communities or all communities or some to have access to broadband and 5G or internet access, they have strategically and intentionally redlined certain areas to not have access or to have access, but they have excluded areas and did not include infrastructure for internet when they did not feel that those areas were profitable. So we are still seeing redlining, and specifically redlining in digital health in the year 2023, which is one of the reasons when we think about society level, why certain communities are still not able to utilize digital technologies in general, but also digital health technologies. Then, of course, economic inequities. So any of us who has internet in our homes or has it on our phones, we know that the cost is not always the most affordable. And depending on the various plans, we know that there's all these advertisements of coverage is the best here if you sign up with this provider and so forth. But we know that we have friends and family that their calls still drops and you're still saying things like, can you hear me now? So that can impact whether someone is able to get a particular plan or service, as well as intersected with the location in which they reside, can impact whether they have access to be able to use these digital health technologies. Then there's absence of technology for some communities. Now, want to recognize here, when we talk about absence of technology, this is not only rooted in a deficit space of a framework of communities reporting that they don't have, but they want. So there are some communities that are reporting they don't have access to digital health technologies because they can't afford them, or because primarily because of cost. But then there are also communities that are absent of technology because they don't see an interest and or need for them, or they have privacy concerns about the use of those technologies. Where's my information going? Who has access to my information? How's my information going to be used? Which that's one of the reasons that I have noted later on, but I just jumped to it. Then there are also the reasons for digital health inequities, such as limited consideration of the role of intersectionality. So some of these digital health technology platforms, such as apps or patient portals or telehealth platforms, whatever it might be, don't always take into consideration one's gender identity, geographic location, economic status, digital literacy, their sexual orientation, things that may play a role in whether they're getting certain tailored information through that digital platform, whether that platform is allowing them to be able to do certain things based on their ability, physically, emotionally, mentally, cognitively, and so forth. Other reasons for digital inequities are digital health literacy. So just like there is health literacy, right? The ability for us to be able to access health information, process that health information, then use that health information regarding certain health decisions. There's also digital health information. So how are we ensuring that individuals are able to properly use it? How are we ensuring that they are able to process the functions that each of those digital health platforms are intended to be used? How are we ensuring that they're able to use those digital health platforms in the way that they are intended and serve their preferences and their needs? So that is one of the reasons. And then we have language preferences. So language preferences is one of the primary reasons that motivated the study that I'm going to share with you that I worked on with my collaborators and for the past 5 years, is because we have learned that digital health platforms like smartphone apps, patient portals, electronic health records are not all, do not all have the capability to provide the health information in various languages. So many of those can only deliver health information in English. And then if they can provide information in other languages, it might be Spanish, but then it's sometimes not always translated in the proper format to have the same meaning that it has in the English term. So that is an inequity as well when we think about how our country and our community is becoming more and more diverse, and how do we ensure that we are creating tools that really speak to the diversity and the beautiful differences that each of our community members represent and identify as. And then the last one is privacy concerns. This is another main thing. So when some of the other reasons why individuals are not accessing or engaging is because there are concerns about, as I mentioned before, where their information and who has it. But we have learned in some of the work that we have done in various projects and what we've seen in the literature, that when community members are being asked to input data information, share information on digital platforms like electronic health records or on smartphones or search engines and so forth, they are wondering if this information might be used against them in a way that could affect their immigration status or impact how they might be treated in a medical setting when we think about the historical issues behind medical racism. And then also, of course, who is having access to that information. So here are just a few examples of some studies that were that informed all of those various reasons for digital health inequity. One study reported and found that telehealth use is inconsistent among Black and Hispanic Latinx households, despite overall increase across general population during the pandemic. We saw an increase in the Hispanic community, specifically for mental health in some studies during the pandemic, but we saw a decrease for the Black community in either mental and or physical health during the pandemic, although telehealth for all communities was at a low pre-pandemic. And even though there was an increase across the general population, there are certain communities within that did not adopt. And some of those reasons for adoption are the things that I noted in the previous slide. We also have seen in some other studies that older Black adults are less likely to use video for telehealth. Well, let's think about that, right? If we know that within the digital divide, some of the factors for the digital divide are connected to age, meaning that typically older adults are less likely to engage in technologies in general. And then we also know that another factor is rural or geographic location because of things, as I mentioned before, like broadband access, digital redlining and so forth. Then we've also seen, and so with that being a challenge, and only using video, being less likely to use video in telehealth, that prevents providers from being able to do a much more in-depth assessment that video would allow a provider to be able to do with an older patient, right? To be able to see certain things, catch certain nonverbals that they would not be able to catch via audio only. So that, of course, can connect to exacerbating certain health outcomes. Another study reported, and we have heard about this more so even more recently as it relates to decolonizing or decentering these white perspectives or Eurocentric perspectives when developing these technologies in wearable devices in accurately detecting biomarkers such as heart rate among consumers with darker melanin or skin tones. So what we found, well, not we, but other scholars have found in these studies is that a lot of these devices did not account for these different skin tones. And so they were using sensors that if your skin tone was a little darker, they would not be able to catch maybe your temperature or maybe your heart rate or other biomarkers that those sensors are intended to do. And why did I state, as it relates to the research and the literature is trying to promote decentering this space of whiteness or Eurocentric views in technology development, is because oftentimes in the technology spaces, there many of the developers primarily are predominantly white. And we are hoping to see that there will be a shift in more developers being more diverse in their identities, racially, ethnically, sexual orientation, gender identity, and all of these other identities that can influence how a device is created and made. But at this time, we haven't seen an uptick yet. And it has revealed some of these challenges as it relates to when these devices have one perspective designing them, it can create or produce some bias or not consider factors that need to be addressed in these devices. Another study reported that many digital health tools do not consider or include different languages, as I already reported. So as a result of, acknowledging and seeing all of these various inequities that exist and that persist in our marginalized and minoritized communities, my colleagues and I started working together almost 5 years ago to develop an app that we believe is helping to contribute to addressing some of these inequities. So before I talk about this particular phase of the project, I want to acknowledge the principal investigator or the PI of this project, the Healthy Me Salud smartphone health information app, Dr. Cynthia Bauer, who is also a director of the Center for Health Literacy here at the School of Public Health, as well as all of my colleagues that worked on the grant and served as co-investigators, Dr. Neil Siegel, Dr. John Dickerson, Dr. Robert Gold, Dr. Madeline Deep, as well as our graduate students that played key roles in the development, design, and analysis of many of the work and the phases of this project. Hopefully I did not miss anyone, but I definitely want to acknowledge their efforts and the work to collaboratively bring this project together. And especially because each one of them brought different perspectives from computer science to public health to information studies. And that, I believe, brought a lot of value to us addressing some of the reasons for inequities in digital health. So what motivated this project was that we recognized that Black and Hispanic adults, according to studies in national studies like in the Pew report, are likely to use smartphones. And so that is great in the sense that if they don't have access or choose not to use a laptop and or computer to access information, they have a smartphone device that can connect them to information, specifically health information. We also learned over time that those who are smartphone users are likely to use smartphones for health information for various reasons, like communicating with their healthcare provider, making health decisions. And so we saw this as an opportunity to leverage a device and a tool that they are using. What also motivated this was us recognizing that, as it relates to those inequities, that there weren't a lot of smartphone apps, specifically as it relates to health promotion and disease prevention, in addressing and acknowledging how language is very, very important when delivering health information. And we saw that there weren't a lot of apps in that space, in that field, that provided information in Spanish. So that was one area that we were hoping to contribute to. We also wanted to contribute with this app because remember, digital health is about using technologies to access health information to prevent and manage health diseases, or illnesses. Well, almost 20 years ago, there was the only health literacy study nationally, represented health literacy study that reported at the time, 20 years ago, that Black and Hispanic adults scored lower in health literacy. Now, I'm giving that caveat that that study is almost 20 years old. So we have not seen a national study be conducted at this time to determine if those data still hold true. So I do want to recognize and note that that study is almost 20 years old, but it is still valuable in the sense that we want to recognize, and we need to recognize, that one of the reasons why health literacy might have been a lower score is not because these communities lacked intelligence or the knowledge to be able to access or process information, but because we know that there are systemic and historical issues as it relates to education access that is a high correlation and association with one's health literacy score. And we know that over time, education within the Black community and across the Black community has shifted some and changed as time has progressed. So it would be very important and valuable if that study was reconducted to be able to see, or conducted again, to be able to see if this has changed. But we still use that data to inform, recognizing that not everyone in our Black and Hispanic community, just like not everyone in the general population, scores high in health literacy. Even those of us who have certain levels of education don't always score high in health literacy depending on the topic, right? So we wanted to see how this tool could support health literacy skills for our Black and Hispanic community members, and also recognizing that Black and Hispanic community members are oftentimes disproportionately diagnosed and experiencing preventable health conditions. So doing all of that informative research brought us to wanting to design this app for the community that would provide personalized health information based on one's race, ethnicity, age, and health status. And doing so, we recognize that before designing this app, we should think about some theoretical foundations that could inform it. Why was theoretical foundations important when we think about digital health and equity? Is because oftentimes many of these apps that are in this space that are not oftentimes academic driven, or they do not hold, or they oftentimes lack a theoretical foundation. So our methodology for designing the app was informed by the consumer processing model and the adult learning theory. And adult learning theory posits that adults will invest in learning when they perceive a strong need to know. Sometimes they need to be made more aware that they need to know something. And so our app was serving in that way by providing them personalized information. We also applied the consumer processing model because this assumes that individuals are limited in how much information they can process. So that was very important, that we're not just bombarding individuals with information, but we're creating a tool that helps them to decipher through that information and store it and manage it in a way that is actually useful for whatever their preferences, needs, and wants are at the time. And then understanding that motivation and goals may affect how much an adult expands to locate or process information. We incorporated that within the app, and then making sure that our app was utilizing health literacy principles, thinking about plain language, making information accessible for them to use, as well as making it supportive in their processing of that information. And then the last key thing in this app participatory design approach was user-centered design. So before we even built this app, we started with this community-based participatory approach, where we wanted to find out from the community how they would want this app to look, how would they want this app to function, what would they find valuable and needed. So as I mentioned before, this project is almost 4 years old. And the first part of it, which I'm going to share with you today, is the design of that app. So I won't be sharing with you phase 2, 3, and 4, as we have just finalized the data analysis for that. And a paper will be coming out soon. But what I will be sharing with you first is how we designed that app to get us to that testing phase. So in the designing of this app and working with the community, the first thing is that we seeked input from community partners such as our Maryland Community Research Advisory Board, and they were very insightful in helping us to determine, what were the best ways to engage in recruitment, what were the best ways to design certain sessions, what were some things that we should include or not include in those design sessions, were there some things as it relates to technology, digital health, smartphone apps that we had not considered. And so they were very valuable in that. We also worked in the Community Research Advisory Board. They comprise of a combination of former policymakers, educators, community-based organization members, varying of different races and ethnic backgrounds, primarily Black community members. And so we then collaborated also with community partners, including community health and empowerment through education and research, also known as CHEER, which is an organization that is a Hispanic serving organization here in the state of Maryland. And they provided a lot of insight as well as it relates to recruitment, the design sessions and so forth. So after taking all of that input, it helped us to develop the actual design sessions that each of the community members would go through to develop this app. There were 3. And so the first design session involved collage and card sorting. So for any of you that may not be familiar, collage and card sorting is this creative process that allows the participants to articulate their feelings and attitudes about a particular topic. Well, what we wanted them to share their attitudes about was specifically how they define prevention, describe their present health, express their health values, and what they desired for their health in the future. And so they ranked certain topics related to health behaviors that they viewed to be more valuable or important to them at the time. They also did collage activity sorting for us to get a better insight on how they defined health and how they defined prevention. And then after gathering all of that information, that helped us to design the actual app prototype. So the app prototype, we then shared with them after building it out with our computer science team for the community members to actually test. So during that second session where you see here interaction with app prototype, we asked them to engage in 4 specific tasks. So first, review the introductory content of the app that describes the app purpose. Does it make sense? Is it something that would be of interest to them? Does this really capture the things that they shared with us in design session 1 for a smartphone app? We also asked them to perform a non-personalized health information search in the app, because one thing that I failed to share with you is that this app would be providing and delivering personalized health information. So meaning that when you entered certain profile data, you would get personalized health information on that. And recognizing that there are privacy concerns within the community, so that was another issue that we were hoping to address that I noted as an inequity. We allowed community members to be able to receive health information in 3 different ways. Either 1, receiving basic health information where they didn't have to enter any personal information. They can just look up, oh, I want to find out how to eat healthier. And they just go into the app, click on that topic, boom, they get that information. Or I want to exercise more, they get that. Or if they felt comfortable providing some information, they could enter just their age, their sex, and their pregnancy status if they identified as someone who wanted to know information related to pregnancy. So when they enter that information, they would get health articles, information specifically on that. If there was a community member who said, I'm comfortable sharing even more information, I trust this tool, they could then receive information specifically based on age, sex, pregnancy status, as well as other health information, such as family health history and health history or health status. And so those various functions of the app during this design session 2, community members gave us feedback on that. Then in design session 3, we asked them to share with us what are some cultural things that we need to be mindful of. And when we say cultural things, we wanted to know, okay, what are some things culturally as it relates to appearance? Should we have certain images, certain colors, certain symbols that should be a part of the design that are reflective of the community in which we are serving? We also asked them about using either specific data or evidence to promote engagement, to explain health information as it relates to the African American and Hispanic health experience, or do they want just general health information? We also asked them to share specifically about language preferences, not only as it relates to Spanish versus English, or Spanish or English, but also if there's certain sociocultural terms that we should be thinking about as it relates to language. And then the last strategy we asked them about are sociocultural values and characteristics. You know, does religion or spirituality play a role in your health decisions? And how would that play a function in this app? Is mental health something that needs to be addressed or focused on? And these were things that actually came up in those discussions. So this session involved participants viewing and rating specific content related to those strategies and telling us what they liked most and what they least liked. And so what we learned from those design sessions is that participants appreciated the opportunity to be heard. So community members want to be involved in this digital health design process. We had a variety of community members as it relates to age, as old as 76 and as young as early 30s. Gender identities, religious perspectives. And so that in those conversations, they were very candid and open about, you know, I appreciate that you all are asking us what we want, what we like, what we prefer. Working together in the design session, they said that they appreciated it because there were certain things that maybe they would not have considered in a digital health app, that when they heard it from their fellow peer or community member, that they were like, that is something that I want, or actually, I'm glad you brought that up because this is why I would not want that in there. It also reduced apprehension about mHealth. One of our older participants, he stated that he was hesitant about being a part of this study because he didn't have a smartphone, but he had just recently purchased a tablet, and he said, you know, I purchased that tablet so I could engage with my grandchildren even more, but I didn't really know how to use it. And I thought that this study might be an opportunity to be able to enhance my skills in technology. And he said that when working with us, he felt that we created a space that made him comfortable. When there was something he wasn't familiar with, he didn't feel that someone was judging him, but that he could learn along as well as share his insight on what he wanted and did not want in a digital app. And it was an opportunity to increase knowledge of how to manage health through mHealth. So there were community members who said, wow, I didn't even know that this was even maybe an option. I've used apps before for tracking like my diet or tracking my steps, but to seek health information, wow, this would be really great when talking with my doctor. This would be really great when sharing information with my friends and family who are living with certain health conditions and just managing my own. And so in the design of the overall app, these are some these are some screenshots that were based on the design feedback that we received. So some of these colors that you see here were informed by different images that they brought in, that they cut up or put in their collage sortings. They wanted things that wanted to be a little more colorful and design appealing, seeing people that looked like themselves. And so forth. So this is just an example, and we're still making refinements, but this is what we got from the prior iteration and then current iteration as they gave us feedback. So what we confirmed is community partnerships are and continue to be key in mHealth research. I know I'm getting close to time. CBPR principles continue to yield promising results. We did not use all of the principles of CBPR, but we used key ones as it relates to engagement, receiving feedback. Interactive design sessions uncover needs and opportunities and give insight to certain cultural nuances, identities that maybe would not come about in those who are designing these platforms. There are multiple approaches in design sessions that provide in-depth understanding of mHealth preferences. So using those various design session techniques gave us insight that we would not have gotten if we had only used, let's say, them just testing out the functions, or only use the cultural strategies, or only use the collage sorting and ranking. So some best practices that we believe individuals should use and model moving forward is using multi-methods, as mentioned before, demystifying what tech is and what tech isn't, because I mentioned to you some of the concerns that we know about in research in general, as well as those that are noted in our study that we conducted, and then addressing biases and inequities in any which way that you can. Of course, you won't be able to address everything in one tool, but what are some things that can help move that needle along? So how can digital health tools continue to address inequities? Of course, involving community members, using these community participatory based or culture-centered approaches, which I'm going to talk more about in my last slide in a few moments. And then creating affordability programs in commercial digital health spaces. So think about ways that maybe how your work informs these policies that can get rid of this digital redlining, as well as create access to those who want to use digital health technology, and then also recognize that digital health should be viewed as a complement to healthcare, but not a substitute. And acknowledging that not everyone wants to engage in technology, but informing everyone about giving them all the information so that they can make an informed decision on whether they want to engage or not. And developing tools that account for the heterogeneity of marginalized and minoritized communities. So we want to recognize and remember that just because a study reports that Black adults are more likely, or Hispanic adults are more likely, or less likely, or Asian community members, or those who speak a certain language, there are differences within each of those communities by age, by gender identity, and so forth. So it's really important to acknowledge, when should we be creating digital health tools that account for that intersectionality versus just digital health tools that account for just this broad stroke of that community identity. And then last but not least, understanding that digital health solutions are not only consumer and patient level. They connect, as I mentioned in my third slide at the beginning of the presentation, at many other levels. So my last point that I want to leave you with is that I always approach my work through the lens of applying a health equity lens, asking myself questions specifically as it relates to whatever the tool or whatever the solution that I'm considering developing. Could this exacerbate issues or make the issues worse? Or is it actually contributing to help improving the issues? How can we consider not only the needs of the community, but not only looking in this deficit lens, but what are assets and preferences of our marginalized and minoritized communities? And how will these digital solutions really address some of the social determinants of health at the program, policy, and service initiative? And then the last part, with my work, I always try to center, as a health communication scholar, this cultured centered approach that was developed by Dr. Mohan Datta several years ago. And he posits that we should be developing solutions that address the needs of communities, what they want, listening to their voices, not this top-down, bottom approach. And I'm sure we are all familiar with this, with those of you that do community engaged work, but this is more so centered around health communication solutions and how we can engage communities about what do they want to see, what do they want to be developed, what should we be taking off the market and reconsidering to support their needs. And those are some things that we learned in our previous study, that design session, that when working with the community, that they told us more things that we need to consider as it relates to mental health, as well as physical health and wellness with digital apps. So that concludes my presentation, and thank you for your time.
Thank you so very much. I would encourage everyone to come online or come on camera and give a round of applause to our presenter, Dr. Jackson. That was fantastic. And please, we have a few minutes for questions, so I'd love to encourage communicate or some discussion here. We have a thank you in the chat. And Amy, if you are still here, I'm trying to see if Amy.
I am.
You are. I don't. If you want to just share the what you shared in the chat with everyone, and as you reminded me privately, you've been talking about this for a very long time and gave one of our early seminars on this topic in 2014. So I'd love for you to share what you shared in the chat, just so that everyone hears that.
Oh, thank you. But I really want to pay tribute to the excellent speaker. As Erica alluded to, I've been doing this for more than a dozen years, but I still learned something and am greatly inspired and encouraged by the work that you're doing. So thank you. Yeah, when you mentioned redlining, digital redlining, I just wanted to point out really to all the people on the call, that Cleveland is where the concept of digital redlining was discovered. And for many years, we were the worst connected medium or large city in the country. However, we can also lay claim to being the birthplace of the digital inclusion movement, which actually got $65 billion with a B dollars in the Infrastructure and Jobs Act for broadband digital equity and adoption. Cleveland is one of the leaders. It's had the most people getting connected to the Affordable Connectivity Program, where they can get free internet. And we also have all three of our health systems collaborating on a common approach to screening patients to identify their gaps in digital readiness, and using the same Unite Us platform to refer patients to these wonderful community-based digital inclusion organizations that are helping them get connected.
Oh, that is
wonderful. So I'll put my email in the chat if anyone's interested in finding out more.
Yes, please. Thank you so much. That is phenomenal.
Thanks for giving me the space, Dr. Jackson, for that comment. As I had shared with you earlier on, I've dipped my toe, but sort of stayed around the edges because some of these concerns, right, of accessibility and inclusiveness. And as I know, many of the folks on the call are local to the area. And that may be a concern. I thought it's just worth mentioning because the work you're doing is so phenomenal. And I think it really resonates with with many of us on the call about the approach and the value of doing this. There's a question from Andrew Abdullah. Hello, will this app or your app be rolled out for all to use, and what's sort of the timeline of that?
Yes, it will. So the PI, as I mentioned before, Dr. Cynthia Bauer, we are in the process of making all of the app refinements with our app developer, Dr. Madeline Deep, who is a subcontractor on the project. And we're hoping to have a rollout in the next, I would say, give or take 3 to 6 months, specifically in the Apple as well as in the Android store. So to make sure accessibility as far as different types of app users. And it will be free. That's always a question that comes up for from community members that have had a chance to test it and those that have viewed it. So yes, that's what we're hoping for within the next 3 to 6 months.
Fantastic. I have a sense that there are many folks who would be interested in helping you roll that out here. So please keep us updated. We'd be happy to promote that through our PRC communication channels and also talk with you about how to help promote uptake here.
Thank you. Thank you.
Absolutely.
Yes, we definitely want to continue extending and seeing ways that we can further enhance the app based on community feedback and input.
Anyone like to come off mute and ask a question of Dr. Jackson while we still have her for another minute or two? Elaine. You're on mute.
Sorry about that. Hi, Dr. Jackson. Thank you. This was awesome. I think this is a space that we're all very interested in. And I think, as Amy said, if the opportunities here is more, we have more opportunity here to do this. Now, what are the steps? I love the approach, the participatory approach. Can you talk a little bit more about the differences you might have seen from the younger and older? Were there, and how to address those issues?
So one thing particularly during the design sessions, the older participants spoke more about, which is kind of expected, disease management information. Many of them mentioned current health conditions that they had. So they were really interested in how the app accounted for that as far as delivering health information specifically for that. And then there were also specific feedback as it relates to certain functions to be able to use them easily because of digital literacy. Whereas on the younger end, as expected, when we think about digital natives versus digital immigrants and how age plays a role in all of that, they reported more about it seemed easy to use and that they enjoyed it. And their topic interests leaned more towards health prevention or health promotion because they weren't reporting of certain health conditions, but mental health was something that came up during the sociocultural discussions across all ages, and how that was an issue, a factor. And what I found interesting about that is because these design sessions happen pre-pandemic, and then to see that post-pandemic, that mental health issues are becoming even more exacerbated and have worsened, especially within certain communities. And it has us thinking, okay, how can we further enhance the app to address those needs?
Yeah. Can I ask one more question? What about this, that you mentioned the privacy issues? How big of an issue do you think that is? And are there specific folks that young, old, like that's a particular issue for?
So what we're seeing as it relates to privacy so far is that it depends on age in general in some groups. Where's my information going? Who's using my information? How's it going to be accessed? Are you making sure there's all these guardrails to protect my information? But then we've also noticed that in certain studies, as well as in some engagement with community members, that privacy concern also plays a role in racial and ethnic identity, specifically as it relates to immigration status. So when I enter my information, is it going to go somewhere that could put my immigration status or citizenship at risk? So that is something that we are being very mindful and intentional about, and why we offer those various options of search information.
Okay. Thank you very much. It was lovely having you.
Thank you.
We're a little past the 1 o'clock hour, and I just, again, Dr. Jackson, want to thank you for your fantastic presentation today. am feeling very excited about this space of work and really love the approach that you've taken and that you've shared with us here. Just as a reminder for everyone, we will go ahead and post the recording. And if you have questions or comments for Dr. Jackson, certainly feel free to reach out directly. And again, we hope we'll see you next month for our May presentation. It's always hard at the beginning of a month to talk about the next month. I feel like it's still March mentally, but next month will be May. And thanks again to everyone for joining. If you'd like to come off camera, give one final round of applause and a wave goodbye to Dr. Jackson. It's been great having you all with us today.
Thank you all, and thank you for the opportunity to invite of the invitation and to share.
Absolutely. Thanks so much, everyone. Have a wonderful day.
Bye.